This is Mrs. Mary Smith, 35-year-old female, G5T3P0A1L3. She is currently 2 hours postpartum. She delivered twins, one male and one female, at 37 weeks. She was in labor for 20 hours and delivered vaginally. She had an uneventful pregnancy and received an epidural. She has had 2 small voids since birth for a total of 300 milliliters of urine. Vital signs have been stable. She has had heavy lochia saturating 2 pads since delivery. She has had hypoactive bowel sounds and had a first-degree laceration requiring 3 stitches. Upon assessment, her fundus was located midline 1 centimeter below umbilicus. Fundus was firm. Her nipples are erect and swollen, but no cracks or bleeding. Breasts are slightly engorged, but no erythema. Mrs. Smith breastfed right after birth. Her last set of vitals, temperature was 99.1 degree Fahrenheit. Respirations are 20. BP is 110/85 with a MAP of 93. Heart rate is 86, and O2 saturation is 97% on room air. She last rated her pain at a 4 out of 10, and her last dose of Percocet was administered 1 hour ago.
Hi, Ms. Smith. I'm Abby, and this is Natasha, and we're going to be your nurses today. We'll start by checking your vitals and performing an assessment.
The patient's blood pressure should be the same as during labor, at least 85/60, but no more than 140/90. A low blood pressure is a sign of shock, and a high blood pressure suggests gestational hypertension. The patient's heart rate should be between 60 to 80 beats per minute. However, slight bradycardia is a normal finding due to elevated stroke volume. The patient's temperature should be normal to slightly elevated, but not above 100.4 degrees Fahrenheit. The patient's respiratory rate should be within normal range at 12 to 20. An elevated respiratory rate is a sign of hypovolemia. The fundus should be located midline 1 centimeter below umbilicus, and it should feel firm like a tennis ball. The lochia should be light to moderate, lochia rubra, with minimal clots that are smaller than a quarter.
Check the uterus.
The latest set of vital signs, our temperature is 97.8 degrees Fahrenheit, respirations are 24, blood pressure is 77/54 with a MAP of 61, heart rate is 110, and O2 saturation is 94% on room air. Upon assessment, there is no change in the patient's breasts. The nipples remain erect and swollen without any cracks or bleeding. They are slightly engorged, but no erythema. Her uterus is foggy, and the fundus is now 1 inch above the umbilicus, deviated to the right. Her bladder is distended. She still has hypoactive bowel sounds upon auscultation, and her lochia is heavy with some dime-sized clots. She is currently saturating 2 pads every hour. Her laceration site has approximated edges, slight edema, and minimal redness with no signs of infection. Her epidural site shows no leakage, minor edema, and no redness. She has regained partial feeling in her legs with minor edema and no pitting on her lower extremities.
Ms. Smith, how are you feeling?
The patient reports increased vaginal pain and is now rating the pain a 7 out of 10. She reports feeling weak, dizzy, and is experiencing chills.
Ms. Smith, you have some excess bleeding, but we'll take care of it. Do you feel like you need to urinate? We need to stop the bleeding. Natasha, if you could start the fetal massage and also see if maybe you can have her urinate, I'm going to go call the doctor.
Yes, go on.
Now that we've realized the patient is experiencing a postpartum hemorrhage, we need to massage the fundus to assist with the bleeding. We can place the mother into the Trendelenburg position. We also need to encourage the maternal patient to void, as a full distended bladder will often be the cause of a postpartum hemorrhage. Applying the moist cloth to the perineal area or running water over the patient's hand will sometimes urge the patient to void. However, when these methods fail and the bladder is full, we may need to insert a urinary catheter using either a straight or indwelling catheter in order to drain urine from the bladder.
Okay, I just spoke with the doctor. He's ordered an infusion of 30 units of Pitocin, Stadol, 1 milligram per milliliter, and lactated ringers. He's also ordered some labs to be drawn.
Okay. Ms. Smith, we're gonna have to put in a Foley catheter to empty your bladder. That might be the cause of the bleeding. Okay?
The nurses will administer IV fluids as well as medications such as Tylenol, Percocet, IV Stadol, or oxytocin, also known as Pitocin, per the provider's orders. The Pitocin will stimulate uterine contractions, which will help stop the bleeding. Once we deliver the Pitocin, we need to monitor Mrs. Smith's vital signs and reassess every 15 minutes. We will need to continuously assess her uterine tone to make sure we are not overstimulating the uterus. Pitocin can sometimes cause nausea and vomiting, so we can relieve these side effects by placing a cold cloth on the patient's head and giving her crackers to eat before getting out of bed. We will also be administering Stadol through her IV for pain associated with the uterine contractions that result from the Pitocin. Oftentimes, Methergine and Hemabate are medications that are given during a postpartum hemorrhage as well. Lactated ringers will increase her blood pressure since she is currently hypotensive. We will also need to obtain labs from the patient to check hemoglobin, hematocrit, and platelets, as well as to type and cross-match her blood in case a transfusion is necessary.
Miss Smith, do you want to try to breastfeed right now? It may help with your bleeding. I'll bring you your baby, okay?
Encouraging the mother to breastfeed her infant will also induce contractions. After she's finished breastfeeding, we will offer a heating pad as needed for pain.
Okay. Finish breastfeeding for right now. Okay. I'm going to bring you a heating pad. That might help your pain as well, okay? Miss Smith, we're just coming back to check up on you, and we're going to reassess your bleeding again.
Okay, so let me see. She has 600 cc's of urine output. Okay.
Okay, Miss Smith, it looks like your bleeding's definitely improved. Our interventions are working. We'll continue to check up on you, Miss Smith.
It was determined that the bleeding was the result of prolonged labor. The 20 hours she spent in labor with her twins contributed to her hemorrhage. The nurse's quick thinking greatly helped Mrs. Smith avoid losing more blood and potentially going into shock or worse. They will continue to monitor Mrs. Smith's condition and any potential future complications.